get my, sorry, going the wrong way. Did everybody get the information I sent on breast? Did everybody look at it? There was some stuff on Ashkenazi, there was some stuff on male breast cancer, stuff on breast cancer, stuff on staging of breast cancer. Did anybody get that?
When was it sent?
Pardon?
When was it sent?
Email, right?
Email.
Yes, ma'am.
I think I sent an email, yeah. Did anybody look at the chapter we're going to do today? Good, so everybody can answer the questions, right? Okay, so let me get this done here. Okay. So I'm going to try something interesting that I've never actually tried before, and that's attaching some videos to the PowerPoint. I don't know whether it's going to work, but if it doesn't work, then I have them on a separate area. Okay, so let me get this organized. So we went through the basics that are in the book, starting from the beginning of the breast cancer chapter. Breast cancer chapter starts on 709. We went through quite a bit of that last week. So we're gonna start again, basically where we left off. So, few questions. What are who is more likely to get breast cancer? Females. Okay. Do males get breast cancer? What percentage of breast cancer patients are male?
More or less than one.
Approximately 1%, yeah. Do they have the same outcome, usually, as females?
They're usually worse.
They're usually worse. Why do you think?
They find it at a more advanced stage.
They tend to find it in a more advanced stage. Why?
They don't really think of breast cancer.
Yeah, exactly. The guys have other things on their mind rather than breast cancer. So they tend to find it at a later stage. Therefore, it tends to be more advanced. Why? Another reason why it tends to be more advanced. Think about the amount of breast tissue you have.
There's not a lot of
Yeah. So if you think about this, if you get a 1 centimeter breast cancer, it still has quite a few centimeters to go through before it reaches anywhere where it can spread outside of the breast. Do the males have the same issue? No, they don't. So therefore, the male breast cancer tends to spread a lot faster than a female was, and it is more aggressive than the female breast cancer. So 40,000 deaths annually. So family history. 2 or more relatives with breast or ovarian cancer. Relatives with both breast and ovarian cancer. 1 or more relatives with 2 cancers. So if I said to you, what type of relative would you be more concerned with if they had breast cancer? Yeah, maternal side, usually. Paternal side really isn't as significant. The maternal side is more significant. So if you have a sister or a mother or a maternal aunt, it's more significant. And the Ashkenazi Jewish heritage, which I sent you a little bit of information on. Okay, so, oh yeah, let's do breastfeeding, alcohol, obesity, physical activity. I think we've got one less than that, okay. So, radiation, obviously, menstrual history. So if you have early menses, if you start menstruating early, ladies, or have an early or stop menstruating early, then you have a higher risk. If you have no children, then you're at a higher risk. If you've never had children, you're at a higher risk. If, however, you have children early, which means under 30, you have a less risk. If you breastfeed those children that you have before 30, you have an even better, or your risk goes down quite considerably. So we went over the unproven ones, antiperspirant, underwire bras, and we had a whole discussion about that, right? Okay. So the Ashkenazi, so this is not Ashkenazis, the genetic testing. What are the two ones that we are all concerned with these days? BRCA1 and BRCA2. They can affect both breast cancer and ovarian cancer. The males can also carry BRCA1 and BRCA2. And for them, it can also do breast cancer, but prostate, and the majority of them are colon. Did you just spill your water?
Just like spluttered
Yeah,
right in
that's
my
what I
face.
thought. I just saw this weird face and I'm thinking, okay, yeah.
It's a little refreshing.
Okay, so clinical presentations. So, American Cancer Society, mammograms. At what age a person of normal risk?
40.
40. Is that a hard and fast rule? So if you are at a higher risk, if you have a mom or a sister or a maternal aunt or all three, puts you at a higher risk. Do you have to wait till you're 40?
No.
When do you start getting mammograms then?
As soon as you find out.
Hmm?
As soon as you find out.
As soon as you can get, basically as soon as you can get, as soon as you can persuade a physician to actually get them organized for you. Some of them are a little, some physicians are a little concerned or downright officious that you have to wait till you're 40. Well, you don't, we have to wait till you're 40. When I was working in Canada, the Canadian Cancer Society's regulations was 50 for mammograms. And I went to my physician and I said to her, I want a mammogram. You're too young. I said, I don't care, I want a mammogram. Why do you want a mammogram? I said, because, you know, where I work, I'm on a machine which treats mainly breast cancer patients. The majority of them are either my age, I was about 42 at that point. The majority of my patients are either younger than I am or the same age as I am. I want a mammogram. Okay. So she sent me off for a mammogram. And then about 2 or 3 years later, they dropped the age to 40. I don't think it was me getting the mammogram that dropped the age to, but you never know. I think a lot of women were starting to object to the fact that the age range was high because they saw the US had dropped their age to 40. So mammogram, clinical breast examination and breast self-examination. So when do you get this clinical breast examination? When exactly. When you go for your yearly checkup and the doctor's doing his or her exam, then they should be doing a breast clinical exam. So what about the breast self-exam? Once a month. Any particular time of the month? Why not before? Yeah, breast changes depending on who you are. Some ladies get sore breasts, some ladies get swollen breasts, some places get both, and you really don't want to have a mammogram when it's that, or you don't want to do a self-breast exam when it's that bad. And magnetic resonance imaging. And we discussed this last week. It's very good for younger ladies who have very dense breast. Mammograms aren't quite that good with dense breast. It's still good, but it's not as good as the MRI. Unfortunately, MRIs are not good for screening. Why not?
They're expensive.
Hmm?
They're expensive.
They're expensive. Anything else? They're not widely available. A lot of people cannot get access to them. So you have to be aware of that. So
I always have ultrasound when I have mine. Is that not a normal?
Usually they do ultrasounds after the mammograms. That's what happens.
Yeah, but it's every time.
Yeah. Have you, I don't mean to be personal, but have you had a lot of breast cysts or breast?
I have very dense.
Yeah, so that's probably why. They probably started doing that and then they just decided to
It's like every
continue.
time. It's like,
Yeah. Normally, if you get sent for a breast mammogram, it's because they see something and they want to make sure that it's a cyst. Because normally they don't want to say anything and scare the hell out of people. But if you get sent for a mammogram, that scares the hell out of people because, they're looking for something odd. So that's usually what happens. And the ultrasound is very good at seeing whether it's a cyst, which is usually fluid-filled, or a cancerous growth, which is not fluid-filled. Okay, so let's see if I can get this to work. If not, I don't believe it's actually going to work. It's going to work. That's scary. Oops.
With early detection, breast cancer is treatable and beatable. Mammograms are the single best tool to find cancer at its earliest stages, long before it can be felt. Yet many women aren't getting them as recommended. One simple test can make a life-saving difference.
And have you ever had a mammogram before?
yeah, the last one wasn't very good.
And why is that?
It was really painful.
Okay, well, I'll work with you to make sure it's not too uncomfortable for you. I'll show you the machine when we get in the room, and it's a newer machine that's been specially designed to have a little bit more comfort with the mammogram, so we'll work with it. Come here.
You notice this lady is rather slim. and it doesn't look as if she's rather big. The one thing you'll notice is that the lady keeps a singlet on, whereas of course you wouldn't, those of us who have had mammograms, they don't do that. You have to sort of strip off, so just, but they actually do show a mammogram actually.
Communicate with me.
So,
Whenever you're having it, we can adjust. So, I need to have your last name first and your birthday. I'm Jeannie, I'm gonna do your mammogram, and there's a cape there for you on the chair. Everything off from your waist up and put it on opening in the front. Now, are you wearing any deodorant? Yes. So I have a wipe over there on the table, so take one of those wipes, wipe off your deodorant, because sometimes it can show up on the image.
Okay.
So just go ahead and change, and I'll be right back to get you after I get them set up. And you can set your bag over here. Now, this is the machine. I'd like you to stand in front, and I'll kind of go over it a little bit with you.
This is the part I remember, the squishy part.
Well, now this machine has gaskets on it, so it gives a little bit when we compress today. We take 2 pictures on each breast. We'll be done here in 5 minutes. It's very quick. The images are digital, and so it goes a little bit faster than the old type machine did. Let's swing your necklace to the back here. And
should come off actually.
what I do is I take a picture from the top like this. I'll bring your breast in, and then I turn the machine to an angle to the side for the second picture. So let's do the first one, the top one first. And you just need to let me know if it hurts in any way when I'm doing the compression. So let's open that right side up. I'm gonna lift up on your right breast. And I want you to just kind of drop your shoulders. And let's rest your hand here. This right shoulder's a little high. Let's go ahead and drop that down. I'm gonna raise it just a little bit. And then we're gonna bring the compression down. Now my machine is ready to shoot, so as soon as we get the maximum compression, I'm going to take your picture. Just try to hold very still. Okay, are you doing all right?
Yeah, that's fine.
Okay, so now I'm gonna go back here and shoot the picture, so hold very still. Okay,
Oh, that
that's
wasn't
one.
bad.
Good.
Anything like it was.
Good, I'm glad. Okay, so we're going to do the angle view now. Okay, as soon as the machine is set, I'm going to turn the machine at an angle. And now we're going to do the same side. So go ahead and put your right hand up on this blue bar. Okay. And I'm going to get behind you here and kind of rotate your body in. And I'm going to lift up on your shoulder and give one more tug so we can get all that tissue in. Okay, here comes the compression from the other direction. Now you let me know if it just doesn't feel right.
Is my chin in the way?
No, the chin is fine. Are you doing all right?
Yeah.
Okay, I'm gonna go back and shoot this picture now. Okay, how was that?
Oh, that's great. It's not
Good.
hurt at all.
Let's go ahead and cover you up in between. We'll do the left side in just one moment. Okay, ready for the left? We'll go ahead and open this up. Relax your shoulders. I'm going to lift up on this left breast. Just kind of drop your shoulders, relax your shoulders. This hand over here. I'm going to give one more tug. Let's drop that shoulder. And here we go with the compression on the left breast. Let me know if it's too much. That looks very good. Okay, I'm going to take this picture now. Hold still, don't move.
Why is it every time someone tells you to hold still, you feel like you're moving?
The exposure is pretty short, so we'll probably have fine pictures, but I will check them before we leave so we know there's no motion. All right, let's do the left side view now. I'm going to get underneath you, bring you forward. You'll forget by next year. And then lift up on your shoulder. Okay, now the compression is going to come from this direction. Ready? Okay, now just tell me if it hurts. Good. All right, that looks very good. Shooting now, very still. Okay, Linda, we're all done.
All right.
Now I want to check your pictures before I send you away, so you can have a seat over here.
Okay.
And I'm going to look over your images.
When will my doctor get his results?
They should be read this afternoon by the radiologist here. Doctor will have the results hopefully by tomorrow. You'll get a letter in the mail if everything's normal. If we need to see anything better, they'll give you a call on the phone.
Okay.
And that's usually pretty quick. So I need to look through your images. Okay, Linda, the position and the compression look fine. So I'm gonna go ahead and send those images over to the radiologist, and you can go ahead and get dressed and go, and we'll contact you as soon as possible. Thank you. You're welcome. Don't forget your purse. Thank you. You're welcome. You're in the first door on the right.
Hello, Linda.
Yeah.
This is Linda from the Breast Imaging Center.
Uh-huh.
You were just here yesterday for your mammogram.
Yeah.
And the radiologist wants you to come back and have some additional views, we call them.
What does that mean?
Well, it means we need to get more information. Basically, we need to get a closer look at an area in your left breast. And we use some special magnification on the mammogram machine to get those additional views. And then while you're here, the radiologist is also here. So he's reviewing the new images, giving you immediate feedback, answering any questions you have, and explaining the results.
Does this mean you think I have cancer?
Well, probably not, because most of the time, all we need to do are get these additional views, about 80% of the time. And that's all we need, basically more information. If we do need to do anything more, we get it all done while you're here in the same day, if at all possible.
And anything more would mean?
Possibly an ultrasound exam, possibly a biopsy. But again, we really don't know until we get those additional images.
So it really could just be nothing.
Exactly.
Okay. So, what do you think? Those of you who have never had a mammogram, did you survive it? It really isn't as bad as it looks. It's a little uncomfortable and you get a little squished, but apart from that, it's not really that bad. It's a little more uncomfortable if you're very slim and you don't have a lot of breast. But for a normal, well, if there is such a thing as a normal patient, then it is not very, it's a little uncomfortable, but that's all. Those of us who have had a mammogram, do you agree with that? It's not too uncomfortable? Okay. So, just chair at the back if you wish.
Okay. I'm coming to watch her, not you. Good morning.
So we've seen the mammogram. Is it possible to get a mammogram in the mail? We discussed this last week. Is it? Yes, no, maybe, kind of, don't know, couldn't care? Okay. It is possible, believe it or not, it is possible. And just to prove that, we have another video.
We're actually going to do a mammogram. A lot of men don't realize that they also need to be screened, particularly if they have family history, but they need to be screened as well. So they need to take breast cancer as critically important as it is for them.
Super tight right here, bear with me. Get some fat fingers out.
Before we start, you see the little, I missed the one on the nipple. You see this little thing here? Yeah. And there was also one on his nipple. That's to give the mammographer and the radiologist an idea of where the nipples are. Also, there's this. They ask you if you've ever had a scar, or if you have a scar on the breast or the chest wall. They'll mark that also, because that can show, that can give us false positive if they don't mark it. Okay, so let's carry on.
It's rare for men to need a mammogram, but
That's
it does
true.
occur.
Yes, we do. I don't know, probably maybe one a month or something like that. They usually do present with a problem, whether it's lump or pain.
I'm Terrence Shirley, and I'm the administrator for the Cancer Institute and the Division of Radiation Oncology at the University of Mississippi Medical Center. We're at the Jackson Medical Mall, one of the outlying facilities for the university. Men should be screened if they find a lump, as a woman might find a lump, and also if there's a family history. We're going to go through the process up until the point of we would beam on the radiation. So we're not going to actually beam on, but we're actually going to do everything else. We're going to simulate everything else as if this was an actual mammogram.
Male breast cancer is very rare. It's less than 1% of total cancers diagnosed. If, 10 men show up, the chances of each one of them having breast cancer is very, very small to none. But that does not mean that it does not happen in men. It does. You have to be vigilant and do the right thing and show up to the breast center. When men feel a lump, it usually freaks them out even more than it freaks out women. Because women will find lumps all the time in their breasts. Men, if they find a lump, they're like, okay, I need to get this checked, which is the right thing to do. But all lumps, like I said, are not cancer. Most lumps in men are completely benign or just increased breast tissue in the breast, which in men is supposed to be dormant. It's not supposed to grow like women. So when it does start to grow in men, for whatever reason it may be, it causes a lump and tenderness. When women find a lump in their breast, they're like, well, there's no family history. This cannot be cancer. It's not true. Don't take it lightly, because 75% of the breast cancer comes in women or happens in women who do not have any family history of breast cancer. Early detection is important to maximize your chance for a cure. Treatment is not as hard, long, or expensive as it would be if it was more advanced.
I think you did great. Most of our men that come in are real nervous and unsure. Most of them work with you pretty well because they're kind of like, okay, I don't want to mess up.
I'm glad I did this. It gives me a better appreciation for what we have over here and gives me a real appreciation for the type of equipment and type of staff that we have. And then when I get a request for this type of equipment, I now know what we're actually buying. It really makes a difference to them.
Okay, so what did you notice about the difference between what you saw in the female breast mammogram, or female mammogram, and the male mammogram? What did you notice? So, well, the nipple thing, yeah. That's supposed to be done on the female as well.
Oh, yeah.
Yeah, well, you didn't see the female breast, right? She was covered in a singlet. The only difference, well, most of the difference is that the male doesn't have an awful lot of tissue to be dealing with. So it tends to be a little more uncomfortable for them, unless their pecs are large. But that's the main difference, really. The fact that they're, as was said in the video, they're really nervous. Most ladies, by the time they get to the age that other lady was, they've had 2 or 3 mammograms. They're used to it. They know what they're supposed to do. But the guys that come in, they don't know what they're doing. They have no idea. They're scared out of their minds, although they're never going to let you show it. But there's something there that shouldn't be there. Men don't get breast cancer. They get prostate. They get testicular. They don't get breast cancer. That's a female thing. Okay. That's the thoughts that go through their guys. So, location. The upper outer quadrant. The breast is divided into quadrants as like the clock. So they've done it to me again. Look at that. Okay. So the breast. So the breast is divided into quadrants. There we go. So, if this is a left breast, then this would be the upper outer. This would be the inner outer, the inner upper. And here. So outer, inner. So outer, upper outer, lower outer. Okay? And the same in the inner. So where do what, if this is the outer quadrant, this is a left breast, the outer cancers, where do they spread to? What lymphatic group do they spread to? Pardon? Axillary, yeah, axillary nodes. What about the inner? Internal mammary chain, yeah. The internal mammary chain runs on either side of the sternum. Sometimes you'll see it in books that's actually called the IMC, internal mammary chain. So right versus left. Anybody give me a guess? You're gonna be 50% right or 50% wrong, whichever way you want to look at it. Any particular side is more common? Anybody care to guess? You're correct. It's the right. And as we treat the right breast, you're fine. What's the problem with treating the left breast, do you think? It always causes problems. You're thinking. What? You're doing this. Yeah, the heart. Yeah, the heart's on the left, so you have to be careful. And we'll get to that later on as we discuss the treatment, okay?
So why is the right one?
They're not sure. It's just one of these things that happens. If you treat 100 ladies, probably 70% of them will be right breast. And nobody's quite sure, except that the theory is most people are right-handed.
And a lot of people sleep on their right side too.
Yeah, but the theory is that most people are right-handed, therefore there's something anatomic that's why there's more right-sided breasts. Now, I don't think that's ever been quantified. I guess it would be a good research project, but for the moment, that's the theory. Where's my thing here? I've lost it. Okay. So, symptoms of breast cancer. Thank you.
Mm-hmm.
Symptoms of breast cancer, ladies and gentlemen.
Pain.
Pain.
Swelling.
Pain? Is that a symptom? Painless.
Oh, yeah, sorry.
Okay. What's the most common symptom? A painless lump or a painless thickening. Okay. What else? Anywhere in the breast? Remember, the breast has a tail. What do we call the tail? Look on the poster there. You see the tail going up into the axilla? What did we say that was called? Called the axillary tail, surprisingly enough, because it goes into the axilla. Or the tail of Spence is another one. Okay? So, anywhere, so you could feel a lump anywhere in the breast, or you could feel a lump in here. Or in here, for that matter. Okay? What else? What other symptom might there be for a breast cancer?
Anything that makes it look uneven or puckered, not
Okay.
symmetric or matching.
What might that be? Pardon? the skin puckered, okay? So that could be just the lump, right, that makes it puckered. If you're talking about peau d'orange, that is a late stage. You wouldn't see that immediately, okay? What about things like discharge? You were talking. You should have said something. Okay, discharge from the nipple is always a sign of something going haywire. The other, the other thing is sometimes if you have an inverted nipple, that it is normal. Some women have inverted nipples. That's normal anatomic differences. But if you don't have a normal inverted nipple and you suddenly see an inverted nipple, that's a sign that you might have to have something going wrong. So you should get that involved, okay? You should get that looked at. So anything that's different. So, asymptomatic. If you go for your normal mammogram once a year, as you're being told to do, and they find a lump on the mammogram, you haven't noticed it. It's asymptomatic. It's so small that you may not have noticed it. A lump or a mass, usually painless, swelling, skin dimpling, nipple retraction, that's what they call an inverted nipple, and the discharge. Those are the most common symptoms. So who usually finds a breast lump? Is it mostly the mammographer, the mammogram? Who usually finds it?
Partner.
The patient, the partner, yeah. A lot of women find it in the shower. And like I said last week, lady came in and said, I don't find it, my boyfriend found it. As long as it's found, don't care. So, the most common ones. The most common is adenocarcinoma. DCIS or LCIS, ductal carcinoma in situ, or lobular carcinoma in situ. What does in situ mean? Pardon? In sight, okay. But what's in situ mean as far as cancer goes?
Has not traveled, has not metastasized, still in its original location.
It's not, in situ means that it's there, it is a cancer, but it has not infiltrated anywhere. It is not an infiltrative cancer yet. Give it a little while and it will. These things are treated. In clinical, we treat a lot of DCIS. It's the most common cancer. The most common invasive cancer is invasive ductal carcinoma. So you change from ductal carcinoma in situ, which is just sitting there not doing anything, to invasive ductal carcinoma. And the lobular carcinoma in situ, again, is just sitting there. And then it becomes invasive lobular carcinoma. Those are the two most common ones. Invasive ductal being the most common, and invasive lobular being the second most common. And that's the two that you will see a majority of them in the clinical site. Inflammatory. We discussed this last week as well. What's the problem with inflammatory carcinoma?
The primary doctor doesn't usually catch it. Because it could be
Why?
infection.
Why?
It could be infection.
Yeah. Inflammatory carcinoma looks like an infectious. It's usually with your family practitioner or your primary care physician. They usually put it down to an infection. The breast gets swollen, it's hot, and it looks like an inflamed breast. Unfortunately, it isn't. It's a very aggressive tumor. They normally are discovered late, and it is usually stage 3 or stage 4 by the time it gets to us. You have mixed tumors. These are all rare. The inflammatory tumor is rare, but you do occasionally see them. The other several ones that I'm going to show you are rare. You almost never will see them. So the mixed tumor, the dullary tumor, the metaplastic, the mucinous, and the Paget's disease of the nipple. Paget's disease is somewhat common because it is a lot of times benign. It is a precancerous condition. But it can easily switch from being precancerous to actually being a cancerous tumor. Nymphoides can either be benign or malignant. Tubular and angiosarcoma. Those are the diseases. So to get back to imaging, the mammography. So what would you think would be the difference between a screening mammogram and a diagnostic mammogram?
Diagnostic is usually if we already suspect something based on clinical findings.
Okay, yeah. So screening mammogram is usually done with both breasts. You go in, you have both breasts done, you go home, you wait for the letter that says, all clear, see you in a year. Or you get a phone call saying we need more views. Or we need an ultrasound. Screening, diagnostic mammograms usually are one-sided. So the diagnostic mammogram would be if the screening mammogram finds something and they come back for further views or an ultrasound or whatever it happens to be. So, potential findings. Calcification, what do you think calcification is?
We look at the mammogram and we do the lumps, the white.
Yeah, the little white splotch, yeah. Calcifications are like little white dots on the mammogram. That's calcifications. That sometimes can be a herald of a tumor. Then you have the mass or a cyst. So ultrasound would be used if they think it's either a mass. They're trying to figure out whether it's a cyst or if it's something that has to be more serious. The ultrasound can show whether it's a cyst, which is usually got fluid in it, or the mass, which is a cancerous mass. And the concerns, well, you get this phone call saying you have to come back for more views, or we have to come back and get an ultrasound. So you're worried. And it's the clinician's problem to let you know what's happening. It's not working today. However, okay, so ultrasound, MRI, and ductogram. That sounds evil. But anyway, an ultrasound we already discussed. The MRI is good for ladies with very dense breasts, especially younger ladies with very dense breasts. Ductogram. What would you think, just looking at the ductogram, what would you think that might be?
Imaging of the ducts.
Pardon?
Imaging of the ducts.
Yeah, and how would we do that, do you think?
Dye.
Dye. Yeah. So they inject dye through the nipple and into the ducts. And then they do, I know it sounds evil, doesn't it? And then they do a special X-ray. It's usually a radioactive dye that they put in. And you can see it there. You got a picture of it?
It's like a tree.
Oh yeah, you get a tree. Okay. I think it's actually, there's one in the book. So it's basically an image of the ducts. So DCIS is the ductal carcinoma. LCIS is the lobule carcinoma, and IDC is the inflammatory disease. Okay. Take a breath. Okay. So.
So hard.
You did great. Okay.
How is he watching it? How is he watching
He does that every year. He has to do it every year because we get assessed every year.
You did great.
Well, thank you. Anyway, lymphatic roots. So we've got axillary nodes, level 1, level 2, level 3. So each of these little, if you look, there is a small little staging group there that shows you all of the lymphatic drainage of the breast. Okay, so metastatic patterns of spread, you go to the lymphatic spread. Next, you go to bloodborne spread. And at that stage, you have extensive metastatic disease. So the most common for breast is the usual suspects: bone, lung, liver, and occasionally brain. But bone, lung, and liver, you'll notice that it's basically the same. Have you noticed that? It's the same ones most of the time. So most of the ladies who have metastatic disease are either bone or lung or liver or breast or brain. And it says other sites. Yeah.
Is it common, like, because I know a few people who have had this, like, they'll have breast cancer and then later in life they end up getting skin cancers on their chests. Is that normal?
It could be that it is not actually skin cancer. It is subcutaneous metastasis from the breast cancer. So it's instead of the breast cancer going to the brain or the lung or the liver or the bone, it goes into the skin and causes little nodules on the skin. But any radiation that you get on your skin, especially if it's then exposed to sunlight, could enhance the actual skin cancer disease. So it could be either or. Okay. So I'm going to send you this stuff. Okay, so we also have a grade. So grade 1, 2, and 3. What does the grade signify? Anybody?
Severity of the dysplasia.
Okay. Something else? What does the grade signify? It's how aggressive the tumor happens to be. So grade 3 would be more aggressive than grade 1. Other factors, estrogen and progesterone receptors and HER2 new. I'll send you some information about that particular one, because it's a little more complicated than we can go into here. So, surgery, breast conservation. Okay, so, excisions. Ductal excision, which means it'll take some of the ducts away. Lumpectomy. What does a lumpectomy do?
Removal of the lump.
Removal of the lump, just the lump. Usually they remove the lump and a little bit of tissue around it. So what would you think quadranectomy may be?
Removal of the entire quadrant. The tumors within it.
Yeah, it sometimes is called a segmental mastectomy, which means it's just a segment. So it will be an upper outer quadrant or an inner outer quadrant or something like that that would be removed. But it's still breast conservation because you're keeping the shape of the breast and you still have breast. So, surgery. So a simple mastectomy, a modified radical, and a radical. So what is a mastectomy? Ignore the simple, modified, radical. What is a mastectomy?
Removal of the breast.
Removal of the breast, yeah. So the simple mastectomy would basically just remove the breast tissue and the skin. A modified radical, which is sometimes these days called a radical, but it's not. The modified radical is the removal of the breast and the majority of the lymph nodes, especially if it's an upper outer quadrant lump, then it would be the axillary lymph nodes would be taken out, all of them. The radical mastectomy, which was stopped being used in everywhere else in the world except the US, in the early 1970s. In the US, it didn't get stopped until about 1980. And the radical mastectomy was you take the breast, you take all the nodes, you take the musculature underneath, so you're left with ribs and skin. And the ladies had a scar which reached from about here all the way across here and down to about here. They had this huge scar. The idea was that, especially in the US, and I hate to mention this, but as we know, in the US, medicine is a business. The more, the better. So that's the reason why most surgeons didn't stop doing the radical mastectomy until basically the women refused to let them do it. The bigger the surgery, the more money was given. So until the patient said, no, you're not doing that to me, did they stop. So that's what the radical was. And I actually have photographs of that now.
So in the radical, did they take the skin, the outer skin as well?
Yeah. Yeah. So basically you had the skin, you took the breast with the skin on it, obviously. You took the musculature underneath and all of the nodes. And then you brought together the skin from the outside, pulled it across, and you had this nasty puckered scar. It really was evil. I never ever want to see one of those again.
There's like nothing left to do a reconstruction if you wanted to.
It was never done. At that era, reconstruction was never even dealt with. It was never even mentioned. So, sentinel node biopsy. Has anyone ever heard of a sentinel node biopsy?
The original node that they suspect is closest to the origin of the cancer, like the first one to receive the cells.
Right, so how do you figure that out?
I think it's the dye again. They inject the dye into that area or into the tumor itself, and then it's watch where it drains to.
It actually is into the lymph drainage. It goes, it's blue. It's a blue dye with a radioactive marker on it, and they inject it into the lymphatic system and they watch where it goes. So you can tell where what they call the sentinel node, which is the first node that the lymphatic drainage of that particular area will go to. So now that you know which of these nodes it is, when you're doing the surgery, you can take the lumpectomy out, for example, or the lump out, and then you can look at the sentinel node. If the sentinel node is negative, then you know that there's no spread to the lymph nodes, because the sentinel node is where it starts. If, however, the sentinel node is positive, then you go forward and you take a sampling of the nodes. So they may take 15 nodes out, and they may find that 3 out of 15 are positive. So therefore you have to treat the nodes. Completion lymph node dissection, or complete lymph node dissection. That would mean that you would be taking out all of the lymph nodes. in that area. And then you have axillary dissection, so they would take out the axillary nodes. Okay, reconstruction. Prosthesis, immediate or delayed, and implants. So there are several ways to do a reconstruction. One is using implants. So they would just as soon as they do the mastectomy, they'll have the implants ready and they'll just put them in, or put it in, actually, because it's only one, right? So you would put it in, and that would be a reconstruction. If, however, they want to do a delayed prosthesis, everybody knows what I mean by prosthesis, right? Yeah, okay. So, if, however, the patient wants to wait for a while until after the treatment has been given before they do reconstruction, there's some problems with that. Anybody give me an idea of what the problem might be? Or one of the problems might be?
Maybe your skin gets fibers or something?
Yeah, yeah. A lot of surgeons don't like working on skin that has been irradiated because it doesn't heal very well. It doesn't heal quite as fast as normal tissue does. So that's one reason. The other reason is that a lot of women would say, okay, we'll do reconstruction later. And then they change their mind, they don't want reconstruction. They'll just do a prosthesis, which means an actual breast prosthesis that they stick into a bra. That gives them a reasonable facsimile of a breast. The other thing that you can do is they can put in, how shall I put this? An air sac. It's actually a liquid. And they put it underneath the skin of the mastectomy, and they'll put fluid in, usually saline. And they'll put fluid into the sac and they'll stretch the skin. So you're actually treating, when you're treating the patient, you're not treating the mastectomy, which is flat, you're treating this, what looks like a breast, but it's actually a bag of fluid underneath the skin, which is stretching the skin. Most physicians, most oncologists don't like doing that because the idea is that the skin has to be stretched every couple of weeks, but you're treating these ladies for 4 to 6 weeks. They don't want the stretching being done, which means the breast gets larger and larger. So they don't want that done.
So normally, the reconstruction is done immediately or is it delayed?
It depends. It depends on the patient, it depends on the surgeon. A lot of the ladies are doing it immediately. These days, most of them are doing it immediately. And again, it depends on the age as well. A lot of the younger ladies, yeah, they want reconstruction done immediately so that they don't look as if they've got, they're sort of lopsided. So reconstruction, so you have tissue flaps. And this is something else that you have to be aware of. So you have the rectus abdominis. Where's the rectus abdominis muscle? It's here. So the idea is that they'll take a flap, they'll put it over the breast, they'll leave it intact so it's still attached to the abdominal area. They'll put it across here, and because they still want the blood supply. These are all done after treatment. So the flap comes from here, they flip it over, they leave it in place because the blood supply is still there. And then eventually, once it's attached itself to this area, they'll cut it off. And it'll become somewhat like a breast. They're not really that good, I hasten to add. And they're also attaching to skin which is damaged from the radiation. So they're not really that good. And the latissimus dorsi is the same. So they're all the tissue flaps. I think they've probably lost somewhat, they don't really do a lot of these anymore. So nipple and areola. So reconstruction. So they've taken the breast away, which means you don't have a nipple or an areola anymore. So they can do reconstruction of those. And usually that comes down to the plastic surgeons who will do that. And they also do tattoos. Has anybody seen that done?
Yeah, there's like, I follow a tattoo artist on Instagram who, his mom just got breast cancer, so he's been like learning how to do it.
Yeah, yeah.
They look really.
They really look good.
Yeah.
Yeah. There was a fair number of ladies when I worked in California, which is California desert, have got a lot of very wealthy population in that area. And a lot of the ladies had that done, and it really looks very, very good. So contraindications to breast conservation. If the patient has wants to keep the breast, would there be any contraindications to that?
Possibility that you missed something and left something behind in the tissue, and it could.
Okay.
What is the word? Relapse?
Relapse, okay. It wouldn't be a relapse if you missed something.
Okay.
If you took something and then it grew back, then it would be relapse. So if you want breast conservation, which means usually a smaller surgery, if you have lesions in 2 different areas of the breast, then you can't have breast reconstruction or breast conservation. You have maybe a tumor on the left upper or the right upper outer, and then a little nodule in the right lower. Nobody's going to do a lumpectomy for those 2. You're going to have a mastectomy. So what would be the contraindications of a mastectomy? Excuse me. Contraindications of a mastectomy.
Swelling from the removal of the lymph edema?
Yeah. Lymphedema. Anything else? You really don't want to do a mastectomy unless absolutely necessary. So if it's a small lump, get a lumpectomy or a segmental mastectomy or something smaller. The only time you should have a mastectomy is if the lesion is either too big or is spread too far. So let's leave it there for our break. Probably it's 10:10. So I will see you back here at 10:30 and we'll go over the chemo. Okay. Minutes, guys.
see where it comes from. Yeah. And then I go back, cause I'm usually like looking down at my notes, and then I look up and she's staring right at me, and I wanna go.
She thinks you asked the question and then you weren't even waiting for her.
I know, like I'm being rude, cause I'm not, you know, making eye
I think
contact
it's hard for
with the
her
mask.
to-
I know. It's so funny. It's at least 3 times, and just this morning, I think is that I've noticed that.
I think I noticed it a few lessons ago, but it must be really hard for her.
Oh, I'm sure.
Guys, how was your weekend?
Nice.
Nice. Sunny. Wow, I wasn't here. I think Aubrey, I don't know what she did.
Took Walgreens sales and she got your nose.
She took she did a, yeah. So let me just make sure you have all the previous training from you this week. It's not really that bad, it's just annoying, but, you know. Well, now I'm doing it. I'm ready to go home. What you guys planning on? No, we don't already.
You guys have been here?
I did with school. I was going home. I'll just with my sisters. It's literally, I like going to my sisters because I don't have to do anything.
Yeah.
She cooks, she cleans. I'm like, okay, I'm just gonna sit here because it's not my house. That's nice. And so, well, I mean, I have to go after all of you, obviously. Yeah. Like, it's nice to just do nothing.
Mm-hmm.
At home, I'm like, oh, I have to do this, I have to that, I have to laundry, I have to do this, I have to do that, you know.
Yeah. I did nothing yesterday because when I work, the nose over the road last week and it just like got worse throughout the day. And so by the time I got home, it was so bad that like every time I like stood up, it hurt so bad. And I wanted to fall.
It's good, I think that's because he doesn't drink water. And he just drinks beer all the time. And
I had a headache too, but once you drink coffee, or like for me, like it never went away. I had to Tylenol, put like rubbed peppermint oil on my head, like that shit works sometimes. Not all the time.
there's a system where my niece sent from that shit.
I still kind of have it, it's just not as bad. But probably by the end of the day, it'll be fucking awful.
Yeah, especially with the spots. Or worse. It's hard for me to sit here awake, especially for the work on my phone. I'll probably do it. You know, oh, I remember last time I was just like this.
Last week, I was like that because I was literally falling asleep. So I was like, yeah, so I usually I was like eating mints and shit, like back to back. I was just like, talking and like,
Oh, I know.
I'm surprised she didn't look at you.
I think she does, like, look at me.
well, she said it was unusual. It's not unusual for you. So it was probably wanted to. I'm right here.
Oh my gosh.
I have the first slide, and that's it.
Verify subscription.
I keep forgetting that. Yeah.
A little break.
Yeah, it looks good. Who has to go first?
Me.
Oh. I think I'm second. When does it start? Is it March 30th?
I don't remember, honestly.
So, I lost like the page. I had all of my pages in here. And it's black.
Are you talking about presentations?
Yeah.
I'm the last one and I'm on April 13th and there's 3 weeks in it, right?
April 13th.
Yeah, and sometime April.
Oh, here it is.
I'm pretty class all day
On the first.
You said I was
Well,
on the
there's,
last.
It is
there's
the
2 or 3
30th.
people
May,
on
March
each
30th.
class, I think. Only one person.
Yeah, I know, yeah.
I'm
But
able
mine's
to.
on like April 20 something. Because you said 3 days on the video, because I missed the first class. And then when I got here, I got April 30th.
Oh, yeah.
Last week, right?
I was like, yeah, we could. Why'd you write this then?
That's so uphill.
And you're the week before me, probably. Yeah. Because I remember he said there was ultrasound and CT left, and I was like, I wonder which one I'm gonna get. Ultrasound sucks.
Think up your ass.
You have to do dry runs with the computer.
We're gonna go up there and start everything.
I'm guessing, he'll probably, like, you know, how he finishes early, he'll probably say, does anybody wanna come up and play on the presentation thing to get practice?
Am I the only one that hasn't started yet?
No.
I started on day 1, and then I did have
I
to
was
touch it
gonna
like
start
a
when
month.
I go back from spring break, that's honestly.
I was gonna do it every week. I tell myself I'm gonna start it this week. Every single week.
I did the majority of it, like, at the
But
beginning, because I wanted
honestly,
that crap
like-
out of the way.
Yeah.
I'm trying to.
I plan on doing that. I just keep forgetting it. Like, it'll be the next week, and I'm like, oh shit, I never touched
I
it.
just have to edit and then turn it, the hard part for me is I'm not good at the slide crap.
How many slides are
I don't know, well, I mean, in theory,
Said it's gotta be 20 minutes.
if you follow the thing, where does it go? You could have as simple as 1, 2, 3, 4, 5,
here, I just can't see that.
6 slides, in
You're
theory.
doing a whole lot of coffee.
Yeah, that would be water.
We got their flashcards from.
I'm gonna try and treat it like
Don't
a
they
CC
start
class.
tomorrow?
No,
I've never even
No.
taken a. So what the fuck do I go? Cause I
The
don't know.
first-
Tomorrow.
the
So
first
I have my
day-
shit in my pants this weekend.
the first day of
Yeah, it's better.
presentations is March 30th,
Yeah, I got it on the first day.
and
Cause
then
we
the
still have
last,
one exam left.
yeah.
So, and then after that, let's start.
The last exam is on the 16th, after
I
you
didn't go
get
to
back.
sleep last night till
Yeah.
4.
Oh, yeah.
My dad was in the hospital. Like,
And then,
I mean,
I don't know what image intensification is. And then 1, 2, 3 days of presentations from the 30th to 13th, and then the 20th is open for whatever.
Who's all on the 30th?
Like, I wrote down.
Yeah.
I'm the first day, and I thought it was tomorrow.
I did think people were going.
Cause he
Oh,
even
the good one,
said,
yeah.
like, come in next week.
It's 3:20.
Wait, he told you what?
3:30.
Last class, he said, make sure y'all come in and start doing this stuff.
Well,
Wait,
no,
you
it's
didn't
like
like practice?
He
Like,
told us
you
to
wanted
practice,
drive
yeah,
Yeah.
on the computer thing, just so that we can, so that on the day we present, we're not fumbling and
Oh
everything.
yeah, I don't know how.
He wants us to get up there and deal with
So
that.
why did he say that last week? Cause I thought mine was.
So you thought you had to present tomorrow?
Yes,
No,
can't
No,
you
you
just
don't
do
have to present
it?
tomorrow.
Well, at least you're ready.
Yeah, maybe the slides.
He was just saying, be ready, be here so that you have time to practice, that's all.
Every time he talks about it, I'm like, oh, yeah.
I've been lazy.
Okay.
I don't think it will. It's-
And then when you texted, I got stressed. I was like, oh my god, I haven't started texting. I was like, oh my god.
I go there and I sound like,
That's a cute picture. That's fun.
I'm talking super slow because I'm
Oh.
Yeah.
I'm gonna be like this.
It's kind of-
Good morning.
Thank you guys. I don't have my outfit resignation.
I was gonna go home
Just
and
all
freaking
stand.
Let's introduce ourselves.
Yeah.
My name is Morgan. I'm so bad. And I am going to be talking about CT.
Mine's on the different list.
I wanted an ultrasound like on that video I was hoping, but then I was like, well, I won't be upset if I get CT because then I'll have an extra.
I tried to find, it's gonna play out loud right now. Everybody would be like,
It's
What are you
like,
watching?
like I kept trying to run a picture of the ultrasound. I kind of want, like, I want to do something funny, like.
I'd love to be funny, but I'm not funny. So. It'll come out really dumb.
we'll laugh at it. We'll just
I had
laugh.
to
Just
do
start
it
chuckling and then we'll be like, cute. Everybody laugh.
Even cheesy is better
I
than like
like-
monotone. Like,
Photoshop my face
Yeah.
onto somebody doing an ultrasound. Like it was me. I did over something in high school. I think it was like future jobs, like different things you're thinking of.
Our break is the 8th through the 14th.
Yeah.
Hey, on my TikTok, like, you're gonna have the biggest problem when she's older, blah, blah, blah. I was like, yeah, she's like, they were like, she's never gonna be able to excel in school if you keep letting her do this shit. I was like,
Do what?
the video of her stuff was right. I was like, first of all, she's already in school and has no fucking problem.
And you're seeing one
So
video.
thanks for your fucking
You don't know
concern.
her from one video.
I was just like, what? These people are psycho. I got a sugar daddy request.
Oh my gosh. I screenshotted a whole bunch of this and sent my friend and I was like, just going through my inquiries over here.
I wish it was real.
$500 for P6.
He said, hi, I want to let you know that you have a beautiful smile. Would you consider having me as your sugar daddy to care for you and take care of your responsibilities? Give you daily.
Is his name Cute Dad?
Yep.
I have
I got the same one.
Oh,
that's why see, I was like, I said it to Trey, I was like, I wish this shit was real.
I got one from somebody named Cute Dad and one from Tom Cliff.
It's not real, especially if they have 0 posts, but if it was real.
Listen, what they do, I'm just saying, they're like, oh, all I want is conversation. Yeah, because they want to know where you're going and when you're alone so they can freaking abduct you.
What is your mom's maiden name?
And then he's old.
Right.
First of all, he's old, and then he said at the end, hit me up if you're down for this.
Right?
That doesn't sound like you're very old. Say, hit me up if you're down for this. That sounds like you're like 20, 30, maybe like. It's just. Trey was like, shit, daily allowance? I bet you. I was like, I wouldn't even tell you if it was real, I'd just do it.
Pay my bill.
I keep seeing these videos, it was like, this is your sign to get a sugar daddy. And this guy like walked up to this Range Rover and bought this girl this outright Range Rover. I was like, fuck you, bitch. Those are the type of sugar daddies that get sugared up.
The other day,
Yeah,
there was
that's
some
me.
guy and he actually tried to
Right.
video call. Huh? Tried to call. Tried to call me through Instagram.
What?
Yeah. And Bob had to be so fast. Oh my god.
Oh my goodness. Okay. So, where were we? Oh yeah, chemotherapy.
I think you should run too. I would do that too. That's even easier.
Most breast cancer patients do have chemo. That's okay, okay. That's all right. You can turn my boots. So they can have a combination of surgery, radiation therapy, chemo, and sometimes tamoxifen, sometimes hormones. If they have chemo, what does neoadjuvant mean? Okay, what does adjuvant mean? Along with, the same time as. So what would neoadjuvant mean, do you think? Before, yeah. So breast cancer is one of the few cancers or that chemo is always done before radiation. And I'm not talking about chemo being done in the morning and radiation being done in the afternoon. I'm talking about chemo being done 6 to 8 weeks before radiation starts. So the chemo is done, as I said, neoadjuvantly. So it is done before treatment or before radiation, actually. Hormones are, in the female's case, male hormones, because you want to basically stop the hormonal reaction to the tumor. So tamoxifen, has anybody heard of this one? Tamoxifen, it's been in the news quite a bit in the last couple of years. Tamoxifen is basically the usual hormone that the ladies start on, and it's usually with postmenopausal or perimenopausal women. So everyone knows what I mean by postmenopausal, right? You're finished your menopause or you're getting there. Perimenopausal means that you're in the middle of. Because how long does menopause take? yeah, depending on how lucky you are or unlucky you are, it can take years. So perimenopausal would mean that the lady is in the middle of menopause. So the tamoxifen is done, as it says, in pill form, and the ladies that are on it are on that for at least 5 years. Yeah. And these other two are the same as the tamoxifen, only they're a much newer version. There was a trial several years ago giving tamoxifen to patients who were at high risk of breast cancer to see if it would stop breast cancer before it started. And the results were unsatisfactory, is what they said. So it didn't have the effect that they thought it would. But it's still being used for ongoing care. And these are just, you're trying to stop the hormones from spurring on the cancer again. Ovarian ablation. What does that mean? Ovarian ablation. What does ablation mean?
Is that burning? Or is it just destroying?
Destroying, yeah. Ablation basically means destroying. So you're destroying the ovaries. And how are we going to do that? Well, there are several ways. You can actually take them out, which basically gets rid of, you're trying to get rid of the hormones that the ovaries are producing. If you take them out, they're gone. You can dump chemo on them. That takes a while. Or you can do what we used to call, many years ago, radiation menopause. And we used to treat the ovaries with radiation to stop their function and induce menopause. So you'd put the lady into menopause. So destroying or ablating the ovaries puts the lady into menopause. Doesn't matter how old she is. If she's 20, she's still going to menopause because the ovaries are not functional anymore. So, to get down to the treatment that we're interested in, whole breast versus partial breast. So, do we want to do breast conservation? This is the ideal. We would want to treat the breast, or what remains of the breast, and we want to, what they call, sterilize the remaining breast tissue. Just because we take a lumpectomy, we do a lumpectomy, take the lump out, does that mean to say that we've destroyed the tumor? No. There may be some little cells going on inside. Now, the lumpectomy patients usually do not have chemo because it's caught at an early stage. So they'll have a lumpectomy and then the treatment will occur. So, patient positioning, supine, arms both up or one up, and the head turned away. So, you saw the breastboard on Wednesday up in the lab. Both arms are usually up. That's the best thing to do. Some physicians still think that just one arm up is fine. However, clinically, it's better to have both arms up. Why?
To have like one position, like so you're not like lopsided, I guess.
Yeah, they're not sort of, yeah, if you put one arm up, it basically twists you. But if you go both arms up, you're stable. So that's why most people now are treated with both arms up, if they're supine. There are some departments in the city and in the US doing prone breast patients, which means they're lying prone. There's a special breastboard that there's a hole in the middle. The ladies lie down and the breast goes into that hole. Rather like the belly board, only it's a breastboard. The majority of them will use that for larger ladies. Large breasted ladies are really very difficult to treat supine. Because? Yes, I've gone, yeah.
So do they just rotate the gantry to like a lateral or like all the way down? Like how do they, if you're prone, how are they, what direction is the beam normally coming from?
They usually go underneath and they raise the bed up so that the gantry is at 90 and 270 and they do them this way. It's exactly the same as they do them supine, only they're lying prone. The only thing that they can't do lying prone is supraclavicular field. And electrons, it's a little difficult to do electrons when they're prone. So, anyway, so both arms up. Why is the head turned away? So if you're treating the right breast, the head usually is turned this way.
So you can get as close as you need.
Maximum room.
More room for what? We're not treating with electrons, you're treating with photons. So why should the head be turned away?
You want as little to like get into that area, like your head, as possible.
Yeah. So if you're doing tangents, which is the area that we're treating, we will not usually, we'll turn the head simply because that's the way it's done. But the majority of the time where the head comes into play is when we're doing supraclavicular fossa. And you want the head turned away because the field comes right over to here and you're trying to get the throat out of the way. If you tell the patients if they don't turn their neck, they're going to get a sore throat. They will turn their neck. So that's the impetus we put on them. So immobilization. So breastboard, wingboard, you've seen it upstairs. Some people do that. Alpha cradle or vac lock. The vac lock is more. Prone breastboard. And the gating or breath hold techniques. So why, okay, so breastboard, we understand. Wingboard, alpha cradle, vac lock. Those are for the supine patients. Prone would be the specialized prone breastboard. What about gating or breath hold techniques? Where would they come into play? Anybody?
I don't remember what gating was.
Breath hold, gating and breath hold techniques. Breath hold techniques are just, and the gating is just a way to control the breathing. So why we were talking about why we take more care, or not more care, because we take care of everybody, but why the left breast is more problematic. Because, as we said, the heart. So what would a breath hold technique or a breathing technique do for the left breast? What are you trying to do? If you're treating the left breast, the heart is here. And we have to treat this part of the breast.
Movement. Maybe minimize.
Chest expands a little bit when you breathe in, so you have more distance between your heart.
Yeah, you're trying to get as much distance between the heart and the treatment as possible. Now, remember, the heart is a muscle. Muscles are usually radio resistant. So really, the heart is radio resistant. However, you don't want to treat anything that you don't have to. And there are some ladies that have heart problems to begin with. You don't want to make them worse. So, you want to make sure that you've got enough distance, or you've got as much distance between the heart and the area. We have to treat a little bit of lung, but you don't necessarily. So the breathing technique would be to try and get that distance. That's what that's all about. Okay, so immobilization, large-breasted ladies. So if you don't have a prone breastbone, that would be the ideal for the broad-breasted ladies. Always considering that they can actually get into the breastbone. They can get up and lie prone. We can use aquaplast, which is the same stuff as they use for making the masks. You can actually put it over and the other breast is pushed flat. That's great most of the time. What might be the problem though with that? Anybody?
If they don't like fall the same way, I guess.
Yeah, yeah. But if you make the, for want of a better word, the mask for this, it should be relatively in the same position every day, you would think. However, the reaction of the treatment on the skin can be enhanced by the mask material or the aquaplast material. So it can give you a worse reaction to that. The treatment bras. I've used several of those treatment bras in my time in clinical. None of them have really worked very well. The idea is that you put the bra on, you put marks on the bra and on the patient, and theoretically, you should be able to reproduce this treatment. Unfortunately, I've never found one that actually works. It's a great idea, but again, you have the problem with enhanced reaction on the skin, especially if they're very large ladies. And you would only use the bras and the aquaplast on large ladies, or large breasted ladies, not large ladies, large breasted ladies. And then you have the decubitus position, which is what? How would you define the decubitus position?
Isn't that on the side
Yeah,
with your knees, one knee up and?
yeah, so you're lying half on your back. It doesn't work either, unfortunately. I have done one which the patient's lying half on their side. They've got a cushion behind their back and they're lying on the cushion, so they're sort of on their side, but they're relaxed down, and the treatment is given like this. And because they're on their side, the breast tends to be a little less mobile, shall we say, a little less floppy. But again, it can be really difficult. And I think that's why when some bright spark came up with a prone breast board, everybody loved it because it worked very well. So, treatment fields. So the beam arrangement for the tangents. What are tangents? I don't think we've gone over this. When we are treating the breast, we're treating, this is the breast piece. This is the breast. This is anterior. This is medial. And this is lateral. So the patient is lying flat, her arms are up. This is the medial, this is the lateral. So we've got a left breast. And you've got lung underneath. So, how do we treat that breast? What would be the easiest way to treat it?
On both sides?
So this way? Why not just treat it straight down?
Then you're treating the lungs.
You're treating the lungs, okay. So you're gonna treat this way. So you've got a field coming in like this, and a field coming in like this. It's what we call tangent fields or tangential fields. You notice that we're treating a little bit of lung there. the breast sits right on the lungs. Thank you. I'll just wait until it stopped. So you're, unfortunately, to get all of the breast in, you need to treat a little bit of lung. So you'd be treating this amount. So the majority of the time, you'll be treating about 1.5 centimeter strip of lung, which in most patients, you can manage. Most patients, unless they have very bad lungs, is good. You can do that. If, however, you say, oh, well, I don't want any lung in there, you're going to be missing some of the breast tissue, and you don't want to do that. So you take a little bit, this is probably a little overindulgent here. Let's take this and we'll do that amount of lung. So to treat the breast itself correctly, you have to treat a little bit of lung. That's all there is to it. You have to. So this is a medial, this is a lateral. These are called tangential fields. And this would be only for the breast itself or the chest wall, depending on which one you're doing. The borders, as we know, the breasts tend to be mobile. They tend to be different sizes. So what you do is for the upper and lower borders of the breast, you take 2 fingers, which is 2 centimeters approximately. You find the upper border of the breast and you've got 2 centimeters above it. So that would be about there. Same thing on the lower. You find the lower, you take 2 fingers, and that's your lower edge of your field. Medial is midline. And the lateral is a mid-axillary line. So you get mid-axilla and you draw a line down. So that's your borders for your medial and lateral and sup and inf.
You said medial was midline?
Medial is midline, yeah.
Do a lot of patients who get this sort of treatment ever complain of breathing issues as a result of treating any issues?
If they have breathing issues, it would probably be about 9 months down the road. We always warn them, or the physicians always warn them, that they may have slight damage to the lungs and explain why. And most patients will say, okay, fine, go ahead. But this type of lung damage is not immediate. It is a late reaction, which means it's 9 months, 6 months to 9 months down the road. So shielding. Are we shielding anything here? Is there anything here, from here to here and from here to here, that we need to shield? No? Okay. Why do we have, and I did this just in case, why do I have what we call flash over here? Here's the top of the breast. You have, we'll do a little nipple here. There, there's a little nipple. Not a large nipple, sorry. So why do we have this flash? This is all air. Why do we have that? Anybody get any ideas why we have that? Yeah, if you're breathing, obviously you're lying on the bed, your arms are up, and you're breathing. depending on how you breathe, you're going up and down and up and down and up, and then you can see we have this little air gap here. This is all air. So we want enough flash over this as possible so that depending on how the patient's breathing, we're still getting all of the breast in the field. Because sometimes the ladies will lie very quietly and breathe quietly. As soon as you go out the room, they'll go, and they'll go up here. So we have to make sure we've got enough leeway so that if the patient does tend to breathe heavily, we've still got enough so that we're treating the whole breast. Energy. What do you think for a normal size lady? We would give, bless you, we would, what energy might we use? We're doing photons, of course, just in case somebody said electron. We're doing photons. What kind of energy would we be using? What's the lowest energy that we normally use for photons? 6. I don't think there's a machine out there these days that has less than 6 MV photons. Would we use anything more than 6 MeV photons? Or MV photons, I should say. Is there anything that, no?
I mean, maybe not for the breast itself, but for the node treatment, would we increase the energy?
What nodes are you looking at?
Like, for example, the axillary nodes, would we stick with 6 MV treatment or would we jump it?
No. Because the nodes primarily are very superficial, so we would keep the 6 MV.
And that's the same thing for the mammary chain as well?
The mammary chain is usually included in the medial field. So remember I said that the internal mammary chain runs down each side of the sternum. So if you're going midline, you're going to be including the ipsilateral side of the mammary chain. Everybody agree with that? Okay, so yeah. So